Hi guys, welcome to today's session of INI-CET recall. The question discussed in this PPT are recall based, and the motive of this live session is get the actual questions asked in exam. Whenever we are going to collect the questions, we are going to upload the questions on the PrepLadder app. Clear? So guys, let's start. Which of the following are complications associated with GRD? Yes, tell me. So here, there is asthma, laryngitis, pulmonary fibrosis, chronic cough. So guys, asthma is also seen, laryngitis is also seen, pulmonary fibrosis, chronic cough, all of these are complications of GRD. The patients who are having gastroesophageal reflux disease, in these patients, all these complications are there, right? So 1, 2, 3, 4, all of these are correct. All of these are correct. Clear? Next question. Which of the following is the most common hernia in females? You know that femoral hernia is more common in females, but the most common type of hernia in both males and females, that is indirect inguinal hernia. So you know, it is indirect inguinal hernia, which is the most common hernia in both males and females. So in both males and females, it is indirect inguinal hernia, right? Femoral hernia, it is more common in females. So femoral hernia, this is more common in females, but the most common hernia in females, that is indirect inguinal hernia. So correct answer is B. That is indirect inguinal hernia. Easy question. It's a repeat question. Next question, guys. Which of the following is not a marker for GIST? GIST, that is gastrointestinal stromal tumor. If you remember some kind of change in the option, please let us know. अगर आपको पता है कि कोई option गलत है, you just let us know, right? Now, you know, for GIST, SDH is a marker. CKIT, you know, CKIT, the marker is CD117. This is the tyrosine kinase receptor. PDGF, that is PDGF, platelet-derived growth factor receptor alpha. So PDGFR alpha, that is also a receptor or marker. But nestin is a neuronal stem cell. It's a marker for nestin is a marker for neuronal stem cell. Clear? So guys, it's a marker for neuronal stem cell. So this is not a marker for GIST. So what is the correct answer here? Nestin is not a marker. What are the other markers? You know, there is DOG1 detected on GIST1 protein kinase C theta, CD34. So all these are markers. Nestin is not a marker. SDH, CKIT, PDGFR alpha, all these are the markers. Clear? Next question. ER positivity. Estrogen receptor positivity is used as which of the following in the context of breast cancer? So you know that it's a prognostic factor. ER-PR positivity is a prognostic factor. So ER-PR positivity, it is suggestive of good prognosis. And if it is negative, it is suggestive of bad prognosis. So if it is negative, it is suggestive of bad prognosis, which is prognostic marker. Clear? Guys, next question. All of the following statements regarding Wilms tumor is true, except, you know, Wilms tumor is the most common primary malignancy, renal malignancy in the children. In which particular age group it is seen? 2 to 5 years. Clear? What is the triad of Wilms tumor? Guys, you know, there is mass, there is fever, there is hematuria. So it is mass, fever, and hematuria. Simple. In which particular age group it is seen? 2 to 5 years. What is the most common presentation? Abdominal mass. Lung metastasis, it is seen in 10% cases, and obviously it occurs late. What is the treatment of choice? Doesn't matter whether the patient is having RCC or patient is having Wilms tumor. In both of these cases, what we go for? Radical nephrectomy. So treatment of choice is radical nephrectomy. Most important prognostic factor is histology followed by stage. If the histological factors are adverse, so if histological factors are adverse, then we have to start chemotherapy, we have to start radiotherapy, and chemotherapy is started within 5 days, and radiotherapy, this is started within 10 days. Clear? So chemotherapy within 5 days, radiotherapy within 10 days. Now see the options. Presence as abdominal mass, this is correct. Most commonly seen in less than 5 years of age, this is correct. Lung metastasis, rare occurs late, correct. Majority patients recover due to chemotherapy and radiotherapy. No, most of the patients are going to recover because of radical nephrectomy. So the treatment of choice is radical nephrectomy. If histological factors are not good, in those cases, we are giving what? Chemotherapy, we are giving radiotherapy. Clear, guys? Next, can you see this is a new question, image-based question. So guys, let's rule out. It's not the central line. Can you see here? These are the needles. There is syringe. Clear? These are the instruments. What? There are 2 scissors given. So this is not the central line. This is not the Ryle's tube, means orogastric tube insertion. This is not the chest tube. So obviously you can rule it out. This is what? Percutaneous endoscopic gastrostomy, PEG. So this is PEG. Percutaneous endoscopic gastrostomy tube, PEG. So this is for gastrostomy. Clear? So this is PEG. So you can see this image carefully. This is PEG. So percutaneous endoscopic gastrostomy. This is a new question. Clear, guys? Next. Again, it's a repeat question. You can see here what kind of crystals are there. You can see this is coffin lid crystal. And you know that these coffin lid crystals are seen in steroid stone, which is also known as staghorn calculi, also known as triple phosphate, also known as calcium, magnesium, ammonium phosphate. Clear? So guys, see here. You can see 45 years old female presents with recurrent episodes of right flank pain. There is hematuria, history of UTI. And you know that this staghorn calculi, obviously it is more common in females. Why? Because females have short urethra. There is increased risk of UTI. Which organism is responsible, guys? You already know. It is protease. Protease is going to produce which enzyme? Urease. And urease is going to break urea into ammonia. So this urease, it is going to break urea into ammonia. And this ammonia is precipitated with calcium, magnesium, and phosphate. So this is triple phosphate. Here, pH 8, alkaline pH. Which of the following is most likely underlying cause of this patient condition? This is triple phosphate stone. Can you tell me, guys, what kind of stone is there in calcium oxalate? Envelope shaped or bipyramidal? If it is dihydrate, envelope shaped or bipyramidal? Bipyramidal. Clear? What kind of crystals are seen in calcium oxalate? Monohydrate, dumbbell shaped. It is dumbbell shaped or hourglass shaped. Uric acid, this is multifaceted, and cysteine, this is hexagonal or benzene shaped. Got it? So guys, this question was asked many times in exam. What is this? This is steroid or staghorn calculi. Clear? So steroid or staghorn calculi. Next question, easy. 52 years old patient diagnosed with invasive ductal carcinoma, not in C2, invasive ductal carcinoma. There is ulceration on skin and inflammatory signs. So whenever there are changes whenever the changes are involving breast skin, like ulceration, edema, pudore, satellite nodules, simultaneously, can you see here, inflammatory signs are also there. Clear? So if inflammatory signs are there, most probably patient is having stage T4D. Suppose it is not mentioned properly that if the skin of breast is not involved more than 30, if involvement of breast skin is there, but the involvement is less than 1/3. Since there is ulceration, ulceration is seen in T4B. So it doesn't matter if it is T4, the stage becomes 3B, and this 3B is locally advanced breast cancer. Clear? So what? It is not stage T4 with node positivity. It is T4B. This is correct. Obviously, stage T4B is stage 3. No metastasis. If you have to choose one answer, out of T4B and 3, even if patient is having inflammatory breast cancer, that is T4D, right? And that corresponds to stage 3B. So stage 3. So stage 3, this is a better answer than stage T4B, right? So it depends on the question what kind of description is given. If breast skin is involved, more than 1/3 of breast skin is involved, then it is T4D. Again, the stage will be stage 3B. And even if it is T4B, involvement of breast skin ulceration, edema, pudorine, satellite nodules. So T4B, what is the correct answer? Better answer would be stage 3 than T4B. It depends on the language. Now, guys, this question, again, a repeat question. Almost every year this question is asked. You can see this is EDH, extradural hematoma. You can see here. Clear? Extradural hematoma. Now, see the question. 35 years old male sustained head injury following motorcycle accident. Experience loss of consciousness at the scene. Upon regaining consciousness, so you can see here what kind of interval is positive. आप देख सकते हैं कौन सा interval? This is lucid interval. He developed severe headache, began to feel drowsy. CT scan is performed. It shows EDH. This large EDH. Which of the following should be managed? Should be the management for this condition? Obviously, we have to drain it. And what is the ideal method? We can drain it by craniotomy. Two methods are there. The drainage can be done by burr hole, or the drainage can be done by craniotomy. So it can be done by burr hole or it can be done by craniotomy. Clear? So what is done here? Anticoagulants, no. You should not use anticoagulants. Only observation in ICU, no. Mannitol to reduce ICP. What? Go for immediate surgery. So here we go for craniotomy. Next question. Again, it's a repeat question, guys. So a 45-year-old patient presented to the clinic with complaints of food regurgitation and weight loss. For past several months, barium swallow is given. You can see here rat tail, bird beak, or pencil tip appearance. Rat tail, bird beak, pencil tip appearance. You can see here this one. What is the triad of achalasia cardia? It is DRA. How to remember? DRA. Dysphagia, regurgitation, and weight loss. Here you can see there is regurgitation, there is weight loss. So it's a classical case of achalasia cardia. In esophageal carcinoma, what happens? The most common symptom is dysphagia followed by weight loss. Food regurgitation is not there. Zenker's diverticulum, there is food regurgitation, but weight loss is not there. Diffuse esophageal spasm, these patients are having chest pain. How to rule out? Diffuse esophageal spasm, chest pain. Zenker's diverticulum, usually weight loss is not there. Usually weight loss is not there. It's not there. Esophageal carcinoma here, regurgitation is not there. So regurgitation is not there. So correct answer is achalasia cardia. It's a repeat question. Okay. Now, guys, this question. A 55 years old male presents to clinic with left lower lip weakness following recent parotid gland surgery. Considering the surgical history and current symptoms, what is the most likely site of lesion causing this patient condition? Now, guys, it is, if you see, the weakness is in the lower lip area. So it is because of injury of marginal mandibular nerve. Clear? Marginal mandibular nerve. Now, what is the problem? Which of the most likely site of lesion? Obviously, it's not the temporal branch, not the cervical branch. Not the temporal branch, not the cervical branch. Obviously, it's not the parotid duct. So most probably main trunk, but actually parotid duct, what happens? We are going to injure some of the branches, right? So this is also unlikely. If mandibular branch is there, that would be the correct answer. So it depends on the options, right? So I don't know whether all these options were there. Mandibular nerve was there in the option or not. So it's injury of marginal mandibular nerve. So it depends on the exact language of the question. Next, which of the following is not a risk factor for cholangiocarcinoma? If you have seen the papers from the last 2-3 years continuously, they're asking the risk factors for cholangiocarcinoma. You know, hepatitis B virus, hepatitis C virus, HIV. Hepatitis B virus, HIV, hepatitis C virus. All these are risk factors. PCS. Actually, most probably this must be primary sclerosing cholangitis. Again, it's a risk factor. Caroli's disease, that is type 5 choledochal cyst. Type 5 choledochal cyst. Again, it's a risk factor. Opis torquis viverni and clonorchis sinensis. Clonorchis sinensis, opus torquis viverni, all these are risk factor. All these are. But in one recall, I saw that primary biliary cirrhosis is mentioned. So if at the place of primary sclerosing cholangitis, if there is primary biliary cirrhosis, then this would be the correct answer. Primary biliary cirrhosis is a risk factor for HCC, hepatocellular carcinoma. It's not a risk factor for cholangiocarcinoma, but primary sclerosing cholangitis, it's a risk factor. Got it? So hepatitis B virus, it's a risk factor. Primary sclerosing cholangitis, it's a risk factor. Caroli's disease, it's a risk factor. Clonorchis sinensis, it's a risk factor. Opus torquis viverni, it's a risk factor. Okay. So if primary biliary cirrhosis is there, most probably that would be the answer. Next, which of the following is not done in primary survey of trauma? Not done in primary survey of trauma. Guys, so in primary survey, what we do? A, B, C, D, E. A means airway maintenance. We do intubation for airway maintenance. B, that's breathing, oxygenation and ventilation. So if patient is having massive hemothorax, tension pneumothorax, we go for ICD. How to diagnose the condition? Chest X-ray. We go for chest X-ray. CT is not done. NC-CT head is not done. So this is not the part of primary survey. It's not the part of primary survey. Yes. So chest X-ray is done. X-ray pelvis is done. Ultrasound means fast is done. But CT, CCT, NCCT, this is not the part of primary survey. Okay, guys. So correct answer is A. Next question. See, 32 years old male presents to emergency department after sustaining a stab wound. You can see here, stab wound on the left side of his chest. He is in acute distress. Most probably right side hona chahiye yahan pe, because the changes are on the right side. So right side. With heart rate, you can see here, heart rate of 120 per minute. So patient is having tachycardia, BP 90/60, pulse rate more than 100, BP less than 100. This patient is unstable. Patient is in the state of shock, so patient is unstable. Respiratory rate 28 per minute. Physical examination, decreased breath sound on right side. Chest X-ray is given. What's the diagnosis? Guys, here you can see clear-cut collection of what fluid. And what is that? Obviously, it is because of penetrating trauma. So obviously, what's the correct answer? It's not pneumothorax, tension pneumothorax, hydrothorax. Excuse me. This is hemothorax. So you can see here, guys, this is a case of hemothorax, right? In one of the recall, I saw that there is whiteout lung. So that is also a case of hemothorax. Clear? So here, correct answer is B. What happens in tension pneumothorax? In tension pneumothorax, there will be depressed diaphragm, shift of mediastinum to opposite side. Clear? And the patient will be having absent breath sounds, not the decreased breath sounds. Right? Pulse rate, again, obviously tachycardia, hypotension. But what happens here? Patient will be having dyspnea and tachypnea. Now see here, which of the following will not result in hoarseness of voice after thyroid surgery? Right? So this kind of question was asked for the first time. Clear? So guys, we have to recall the question completely, then only I would be able to tell you. Now let me tell you what's the cause of hoarseness of voice. Hoarseness of voice, it's because of injury of recurrent laryngeal nerve. Where we are going to injure this recurrent laryngeal nerve? Recurrent laryngeal nerve is injured where? Near ligament of, yes, berry. So what happens whenever we are going into tracheoesophageal groove? We have to be very careful. We are not using cautery. And if any kind of bleeding is there, we have to control it with pressure. Clear? Right? So this recurrent laryngeal nerve, when it is injured, right? Whenever we are ligating inferior thyroid artery, during that time, there is injury. Whenever we are ligating superior thyroid vessels, there is injury of external branch of superior laryngeal nerve. Injury of external branch of superior laryngeal nerve. Clear? So it depends on the language. We will discuss it. Next, Mount Fuji sign. So Fuji sign on CT is seen in which of the following? So obviously it was discussed in radiology. That is pneumocephalus. It's a radiology question. Next, a 20 years old chronic alcoholic presents with severe hematemesis. Ultrasound shows distension of portal vein. So there is distension of portal vein and liver appears hyperechoic. Okay, guys? Pantoprazole has been initiated. Next appropriate step. So whenever there is upper GI bleeding, what is the first investigation done? In the patients of upper GI bleeding, the first investigation done is endoscopy. And what is the treatment of choice in upper GI bleeding? We have to go for endoscopic varicose ligation. So preferred treatment, endoscopic varicose ligation, followed by endoscopic sclerotherapy. Endoscopic sclerotherapy. So we have to control the bleeding. So initially what we give, we start the pharmacotherapy, we give octreotide, we start pantoprazole, initiate a course of broad spectrum antibiotics. No, after controlling the bleeding, when we are shifting the patient to the ward, we start antibiotics. Liver biopsy immediately, it should not be done. Administer IV fluids and electrolyte replacement, obviously yes. And after that, when patient is stabilized, we perform endoscopy. So it is C followed by D. It is C followed by D. Clear, guys? So first IV fluids, electrolyte replacement, followed by D. Clear? So these were the questions. There was another question related to medullary carcinoma thyroid. Anybody remembers that? Yes, what was the question, guys? You remember? So there was one question that patient is having midline swelling in anterior part of neck. Patient was having diarrhea, history of amyloid stroma. There is presence of amyloid stroma. So in these cases, what is the origin? So all these factors are suggestive of medullary carcinoma thyroid. So medullary thyroid cancer, and you know that medullary thyroid cancer, it arises from parafollicular C cells. So it arises from parafollicular C cells. Okay, guys? So if you remember some other questions, please send those questions on my mail ID. This is drpritesh@gmail.com, or share on Insta. Clear? So you can share all those questions so that we will be coming with a better recall of all the questions. Till then, guys, take rest, relax, and just don't lose hope. Definitely, you're going to crack this exam with flying colors, and continue your preparation for the next exam. Okay, good luck from the PrepLadders team. Bye bye.